So we're very fortunate today to have an international guest, Jane Buxton from British Columbia, who'll be participating in today's event. Jane's got an international reputation. She's quite formidable and a leader in the field of harm reduction, and certainly the circumstances in Vancouver and British Columbia are really something that's very important to hear about. We hear about it a lot in our field of work, and today provides us a great opportunity to hear it firsthand. Before I begin with other introductions, I'll just do a welcome to country and pay my respect to the traditional owners of the land we're on, wherever you may be, and also I pay my respect to Aboriginal elders past, present and emerging. So thank you everyone for participating in today's special event. At this stage, I'm going to hand you over to Jessie Young, who have built up a bit of a relationship at the Melbourne School of Population and Global Health at Melbourne University. Jessie's an NHMRC Emerging Leadership Fellow at the school. He's not American, he's actually Canadian, even though he loves that slide in the background. Jessie specialises in psychiatric epidemiology and in data linkage work, methodology. He's doing some amazing work at the moment, about to commence in the area of ADHD and substance use disorder. At some point in the future, I'm hopeful that Jessie will be able to talk to us about that cutting research as well. At this stage, I'll just hand it over from you, Jessie. That's the end of my my bookend appearance.
Thank you very much, Sam, and welcome everybody. I'd also just like to start by acknowledging the traditional owners of the land that I'm on, which would be the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present, and emerging. It's my great pleasure to introduce our topics for the day and our keynote speaker, and also a very distinguished panelist. So I'll just give you an overview of the topics. So we're going to have a keynote presentation by Jane Buxton, entitled Colliding Public Health Emergencies in British Columbia, Canada, Challenges and Opportunities for Overdose Response. And the presentation will highlight insight into harm reduction in British Columbia, including topics such as mobile outreach, peer work, naloxone distribution, decriminalization and safe supply models, and other measures and opportunities in harm reduction. That will be followed by a presentation on Addicted Australia, and that will be done by Professor Dan Lubman, who's the Executive Clinical Director at Turning Point, and also Steve Michelson, who's the Campaign Director at Rethinking Addiction, to hear about an exciting new series to be aired on SBS termed Addicted Australia. And that'll set to air on the 10th of November, and has a real potential to make addiction treatment and research a national priority, which obviously is of great importance. And so we're really privileged today to get a bit of a sneak peek at that exciting program. So it's my pleasure to introduce Professor Jane Buxton. Jane is a professor in the UBC School of Medicine, or School of Population and Public Health, and medical lead for harm reduction at the BC Centre for Disease Control, where she chairs the Intersectoral Provincial Drug Overdose and Alert Partnership and oversees the provincial harm reduction strategies and service program, including take-home naloxone. She is involved in the overdose response epidemiology and uses quantitative and qualitative methods in her research. Jane is committed to including the authentic voices of experts, people with lived and living experience in developing policy, program planning, research, and evaluation. And before I hand it over to Jane, I'll take this opportunity to also introduce, we're gonna have a panel afterwards involving Nico Clark. And Dr. Nico Clark is the medical director of the medically supervised injecting room at North Richmond Community Health. He has worked as the clinical director of drug and alcohol services in South Australia and for the World Health Organization in Geneva. So at this point, Jane, welcome, and I'll turn it over to you.
Can you see my slides?
No, Jane, we can't.
Okay, it worked last time.
Yes.
I'll just move it along. I think what I did was I changed the screen so that I could actually see what I was doing. So let me try again on the other.
That's it.
Okay, and I will go. There we go. Well, thank you very much for the introduction, and I am delighted to be here. It's my early evening and obviously earlier in the day for you folks, and I always enjoy sharing my experiences and hope they'll be helpful. We're obviously seeing different situations in Canada than is seen in Australia, but I think we can obviously learn a lot from each other. I'd like to start by acknowledging that I am grateful to live, work and play on the ancestral, traditional and unceded territories of the Coast Salish people. I start off by saying I have no conflicts. As my introduction said, I work at the BC Centre for Disease Control as medical lead for harm reduction. I hold various grants from various agencies within Canada mainly, and I have no industry funding. And the views I will express are those of myself, not of the people who have provided the data. And the data I'm going to share is from many, many folks, including members of the Drug Overdose and Alert Partnership that Jessie mentioned, but also perspectives from health authorities, from coroners, from emergency health services, as well as people with lived and living experience, and an amazing amount of staff as well. I just wanted to start off, because some of my presentation is involving numbers, to actually say that they may be numbers, but these are people. And this is Burrard Street Bridge, which is a main bridge in Vancouver on Overdose Awareness Day, which I'm sure you're all aware started off in Victoria nearly 20 years ago. And Mums Stop the Harm, which is a group of mums who have children who have either died or are suffering from substance use and addiction, they tied a pair of shoes for every person who had died, and within those shoes was a story. It was the name of the person that had died. So just a reminder that I may talk in numbers, but these are people who are loved, that are no longer with us. Quick overview of what I'm going to say. I'm going to talk about overdoses. We now call them illicit drug toxicity deaths. They used to be illicit drug deaths, but I think it's the toxicity that's the problem. And with the deaths and the paramedic-attended overdoses, the toxic drug supply, harm reduction initiatives that we have and are expanding, harm reduction client survey, peer work, and also opportunities that COVID-19 has provided. It's made things worse, but we have to take every opportunity we can. So our overdose crisis due to opioids was declared 4.5 years ago, and it is still ongoing. And as we know, overdose impacts populations, people who are marginalized, who are living in poverty, are homeless, live in precarious housing, have food insecurity, unemployed, and use substances. And COVID-19 has come along and has compounded all these social and health inequities. And the physical distancing that was implemented, as you all well know there, leads to challenges with accessing services. People are disconnected from their usual supports. It may be a drop-in centre, it may be their family physician that they see regularly. That is now, most of the consultations are virtual. Increased isolation and despair, and that may lead people to initiate or reinitiate or even use more substances. And because of COVID-19, the drugs themselves are more toxic. And I'll address some of those as I go along. So we saw this sudden increase in 2016. It was early 2016 that our health minister, our public health officer, declared a public health emergency. Up until about 2014, we were seeing probably about 20 deaths a month. So far less than one per day, at about 200, 250 a year. And then after 2015, you can see it went up, and there was this sudden increase in 2016 at the end of the year. And we've been seeing 4 overdose deaths a day since then. We have increased all our services, and we were really quite hopeful that in 2019 we were seeing a little bit of a leveling off. It was still much higher than it had been, but then COVID happened. And you'll see from my graphs there'll be a dotted red line, and that red line is when COVID was declared, the pandemic was declared a public health emergency. And the numbers just skyrocketed. And we had 3 months with the highest ever overdose deaths, with June being the highest at 183. As I said before, it was about 20 per month back before 2015. If we talk about when these are happening, there seems to be an increase around the income assistance payment week. It's every Wednesday, it's on a Wednesday once a month, and sometimes there's 4 weeks and sometimes there's 5 weeks between. And we do usually see that the 5-week interval is highest. But it's not just that week. You can see it's higher also on the other days of the month. So who is it that we're seeing that is dying? The highest rates are in the 40 to 59-year-old age group, followed by the 13 to 39. And males are more than females, probably about 4 times the amount in our deaths. We also, unfortunately, are seeing a higher rate in our First Nations community. First Nations people make up about 3.3% of our population in BC. And you can see here that it was 16% of the deaths. So 5.6 times the rate in non-Indigenous, non-Aboriginal populations. We also look at where, and I think you can see from the data I'm showing that we are really fortunate to be working very closely with our coroner's office, and we just last week got our numbers for up until the end of September. So it's fabulous that we get them so quickly, and they also share lots of information as we've requested more and more, and they've risen to give us what we're asking for. Most of the deaths you can see here, and certainly the numbers on the right are what's happened in 2020 so far. The majority, over half, are in private residence, and about a quarter are in other residents. And that's similar as it has been since 2017. We have regional health authorities. There's one health authority, Vancouver Coastal, where it's different, it's the reverse. And Vancouver Coastal is where the downtown east side is, which is an area of high substance use, and there's a lot of supportive housing, rooming houses, single room occupancy. So it's really that those services are available rather than being more people dying in those kind of services. So that was the deaths, a quick run through. As you can see, it's been really tragic, but simultaneously with the increase in deaths, we see CAR 23, and these are ingestion poisoning calls. So when somebody calls 911, as it is here, I don't think it is in Australia, the dispatch will decide that that is an ingestion poisoning call and will alert the paramedics that's what they're going to. And this we get on a regular basis and in a timely manner as well. And you can see that the numbers were highest in July this year, having gone up from a slight decline into at the end of 2019, beginning of 2020. This is showing us at that weekly, and you can see there's a number of weeks when it's been really high. There was only one previous week when we had been above 620 for the ingestion poisoning calls. And these are the paramedic-attended overdoses. So the calls are when somebody dials 911 and the dispatch decides, yes, this sounds like an overdose, and tells an ingestion poisoning and tells the paramedics. This is when the person has been seen by the paramedics and either taken to hospital or the person may refuse. But we do have more details, but this takes a bit longer to come. And you can see here that the highest rate is in the 19 to 39-year-olds, followed by the 40 to 59-year-olds. So slightly different from the rates in those in the decedents. So I mentioned we have a toxic drug supply. So why is that? Well, I think we're all aware of the lockdown restrictions, which may affect import and export of drugs and precursors, and affect the production and also people's ability to travel. And as we all know, China was affected early, and that is where much, we're informed by our enforcement folks that much of our fentanyl and our precursors actually come from China. Drug shortages led to price increases, and local production and new dealers were hypothesized. And I'll talk a little bit about that when I come and show you what we've been seeing. We do have a number of early warning meters that we look at, measures that we look at. One of them is drug checking. So we have fentanyl test strips and benzodiazepine test strips, as well as the FTIR machines to test substances. And these are at our overdose prevention sites. But because of COVID, this testing was reduced dramatically, so we weren't able to really see what was going on in the same way. Another data source that we have that we find really helpful is the urine drug screen. So when somebody is on opioid agonist therapy treatment and they submit a random urine screen, the lab that does it, if they detect fentanyl, will also check for fentanyl analogs. And if they identify benzodiazepines, they will identify what sort of benzodiazepines are in there. And again, because there wasn't that same face-to-face consultations occurring, there was a reduction in that amount of data that we were getting that way. Similarly, our Health Canada lab, which does the police testing, had reduced capacity to make sure that there was physical distancing within the laboratory, and we're focusing on priority samples. Health Canada lab is really helpful in testing some urgent samples. If something is happening, the police can pick up a sample and take it to the lab, and we can find out what it is. And also the Provincial Toxicology Lab, which is the lab that does the testing for the coroners. They also had reduced capacity. A lot of their staff was seconded into working with the COVID analysis. So we were seeing fentanyl and its analogs are still the major drug that is implicated in the deaths. And I'll talk a little bit about benzodiazepines and the increase in smoking. So this is what we get from the coroners. They have found, from the Provincial Toxicology Lab, about 85% of illicit drug overdose deaths, where drugs are determined as being the cause, 85% have fentanyl detected. In 2020, it's a bit lower, but that's mainly because not all the specimens have been tested yet. So I know that's very different from what you're seeing in Australia, but this has been, we went from about 4% back in 2012 right up to 85% now. The other thing we've been seeing recently is the extreme fentanyl concentrations that have been identified in the decedents. So it's almost doubled. So from beginning of the year, 8% there was, of the cases, there was over 50 micrograms per litre. And then in the past few months, it's been 15%. And of course, we don't really know why that is. It could be because there are dealers and producers that may be less experienced and may be selling more potent drugs. Or it may be, as I mentioned before, that people are actually using more. They're not going out, they're feeling despondent, they may be using on more occasions. This is another graph which shows to the left, it's detected by in the death. So this is the decedents, and you can see that we did have a spike of carfentanil, which, as I think everybody's aware, is a very potent analogue of fentanyl. And we had a number of cases back in 2019. It seemed to die away, but we've been seeing a few more since, with 34 deaths in 2020. The graph on the right is from Life Labs, which, as I mentioned, is from our urinalysis, the urine screens. And you can see the blue line is fentanyl, carfentanil. So if fentanyl is requested, they detect fentanyl, then they will look at others. So you can see there's a low level of furanylfentanyl, cyclopropyl fentanyl has been up and down. We have had a couple of peaks of U47700, but carfentanil has been the main one that has been implicated. And that obviously, not surprisingly, follows along with what the coroners have been seeing. And we can see that it has gone up again just recently when we've seen that increase in deaths. But this also tells us there's a lot of people who have been using carfentanil, probably unknowingly, but it doesn't always lead to death. So these are people who are submitting their urine screens. I mentioned benzodiazepines, and what we have been seeing is an increased number of opioids that have benzos in them. So this is with the drug checking service. So when somebody goes to their overdose prevention sites and asks for their drugs to be checked, they will check them for opioids, they will check them for benzos. And what we've been seeing, and they don't actually, they use the benzo strips there. What we find is that it seems to be an increasing amount of etizolam that's being found. That graph to the right is from our Life Labs data. And you can see that when benzos are identified, about 60% of it is etizolam. And we did have a slight peak of the flubromazepam, but that seems to have died away now. And what we do know too is that to actually test with the test strips for benzos, that you need to put the sample in with the water and shake hard before to try and get it to dissolve more. It's not as soluble as some other substances. And these are the types of drugs relevant to the death. We think that the fentanyl is the main cause, but these are in sufficient quantities for it to be relevant. You see cocaine is fairly flat at 50%. Heroin kind of has gone down to below 10%. We really don't see much heroin anymore. It's mainly fentanyl or heroin with a small amount of heroin with lots of fentanyl. And you can see other opioids and alcohol and methamphetamine. So methamphetamine, again, it's implicated in about 30% of the cases. We, and often, as you can see from those numbers in that previous graph, that there's a lot of polysubstance use, that people are using substances. It doesn't mean that the substance is contaminated or adulterated. It often means that people are using more than one substance in that period of time beforehand. In fact, this was our September drug checking results that we had, and it was quite unusual to see 4 fentanyl positive cases in the stimulants. We usually don't actually see any, and we did have some overdoses occurring where there was cocaine that was contaminated with fentanyl. And again, we don't know where it was contaminated, where that happened, but it's fairly rare. The drug analysis service, this is the police checking service, and you can see here that when they are testing, and they're testing usually samples removed from people who are going to go to court and have pleaded not guilty, they will test, and you can see just under 10% of samples of cocaine have fentanyl identified, and similarly with methamphetamine, it's slightly higher. Now, some of this may be contamination. This isn't really the amount that's in there because it's fairly sensitive, and it could be that these are being stored or manufactured in the same site. So, or even we don't know whether these samples are large volumes at a production level, or whether they're an individual where there may be contamination from a scale or something like that. So that's the substances. So I've talked to you about the overdoses. I've talked about the substances that have been identified. So now I'm going to talk about our harm reduction initiatives. And I think these are some of the points that you may be very interested in. So we look at our, again, we have this data, not quite as up to date, unfortunately, as some of the other data sources we have. We can get this, but it's not publicly available at the same time. So this is showing the number of patients who are on, clients who are on opioid agonist treatment. That dark line at the top is the total number. You can see the blue line is methadone, which has been pretty static, pretty stable throughout. But you can see there has been an increase in the Suboxone, which is the darker, is the orange line there. And Suboxone is first-line therapy now in BC. It's the kind of one that people now get started on. I thought obviously it being safer than perhaps the methadone, and for some more acceptable. But of course we know that starting people on Suboxone, we need to have a washout time, or we don't want to put people into withdrawal. So there's a number of ways that this is being done. There's somebody in the emergency department, there's a study where people are given Suboxone to go and are able to start after a period of time when they no longer have the opioids in their system, and microdosing initiatives are becoming quite popular. We have overdose prevention services, and we have supervised consumption sites. And I think you're probably all aware that Insight opened back in September 2003, and in BC it was the second supervised consumption site, but it was the first that was kind of legally supported. The first one was actually a Dr. Peter Center, which is a housing for people with HIV and AIDS. But Insight opened in 2003, and there's been a lot of work done evaluating and looking at it. For us to have a supervised consumption site, we need, because our drug laws are federal, we need a Section 56 exemption to allow people to have substances within the facility. So when we started seeing, you remember that huge increase in 2016, and we were seeing an incredible number of deaths. We had a number of applications for various supervised consumption sites across the province, but it was just taking so long to get through the official ways. We had our emergency, public health emergency related to the overdose declared in 2016 in the April, and our health minister developed a ministerial order in December 2016, and this was under the Emergency Health Services and Health Authority Acts, saying all the health authorities will have an overdose prevention site. So this was where people could inject substances and be observed and be resuscitated should they overdose, but it did not have the official Section 56 exemption. And these were started up across the province. Since that time, because other provinces have also had an increase in overdose, and there has been the issue with getting supervised consumption sites approved, other provinces, that Health Canada came out and said, in this emergency situation, all provinces can have overdose prevention sites and have various regulations that you go through, but it's not the same as a supervised consumption site. So as of June this year, we had 32 health authority funded observed consumption sites, of which 10 were supervised consumption sites and 23 were these overdose prevention services. 2019, there was an average of 60,000 visits a month and about 400 overdose reversals. To date, we have had no overdose deaths in any of the supervised consumption or overdose prevention sites. So you can imagine at 60,000 visits a month, this is a huge number of people have gone through, and a large number have been resuscitated and given naloxone. Often when somebody overdoses, they don't necessarily need naloxone, they have all the other pieces there with oxygen and staff to observe. There's also other overdose prevention sites, and for example, Vancouver has about 25 sites in housing settings, which are called HOPS, Housing Overdose Prevention Sites. And these are not ones that necessarily report, so they are not contained in those 32 that I mentioned. And the pictures below just give you an idea of that diversity that you will see. So there is the sort of more utilitarian type of table and chair on the left, and then the orange, which is in a more of a housing site, and then a couple of examples of our mobile sites. Like I'm sure many others, there are some communities that do not want a fixed site in their neighbourhood, and the mobile site is the first one you can see, has 2 places that it goes to every day at certain times. And people know that it's there and can go in and use. And then the other one is in the downtown area of Vancouver. There was need for more sites. We had, when we've been trying to make sure of physical distancing, some booths were closed, so there wasn't so much capacity. And people just weren't using them because they were staying closer to home. So that was another reason for having that mobile site. So as I said, there was a decline in use, client concerns, but also this was an opportunity for peer workers to do on-site peer witnessing. People are equipped with overdose response and will witness somebody in their housing who is using and can respond. And also the peers are part of outreach services and mobile overdose response, so can be called to witness. But this gives you an idea of the numbers. As I said, we were really up to 60,000 that were being seen, and then it went down. It actually was going down in 2000, at the end of 2019, and it may have been because there were less overdoses, that people were less concerned. It may be that more people were smoking and didn't feel they needed to, or there was limited numbers of overdose prevention sites where smoking was allowed. But you can see when COVID hit, it plummeted, and there's just been a gentle increase since that time. Our take-home naloxone program's been going since 2012. Just to point out, we have a silver cross on our naloxone kits. We started off with a red cross, and we thought on a black background and with naloxone written on it, it should be fine. But we were told by the Canadian Red Cross that we weren't allowed to use that. So because silver is the color of the ribbons for Overdose Awareness Day, we decided to have a silver cross. And I think we were going to patent it so that anybody could use it. We have online training, which is an app which takes about 5 minutes to make sure we have standardized training. We have a site finder, so you can put your postal code in and find your nearest overdose prevention site or your nearest place to get trained and pick up naloxone. We have over 700 pharmacies across the province, 20 correctional facilities and 86 hospitals. And we've had 69,000 overdoses reversed. This is a vast underestimate because there's many, many more, but we're not getting the data collected in quite the same way. But this gives you an idea of the number of kits that we're shipping out to our sites. And I think it was 29,000 kits were shipped in July alone. So it's a huge number. Wanted to share a little bit about our client survey. We have lots of data sources, as you saw, using ambulance, using police data, using coroner's data. But what we wanted to find out was what people were actually thinking they were using. And we had this survey for 4 years in a row, 2012 to 2015. And then in 2018, we started again, knowing that what people thought they were using probably wasn't necessarily what it was. Also got some funding from Health Canada so we could include urine screening as well. So we changed from asking in the past 7 days to asking in the past 3 days, because that would correlate with what we were seeing in the urine. And this is just to give you an idea. You can see how crystal meth, which I know is a huge issue for you folks there, went from less than 20% in 2012 and is now at 72%. So it's huge for us. And that's, in the past 3 days. And you can see how cocaine and crack has actually gone down. We ask about opioids. These are different scales, and you can see it's about 44% who use opioids, fentanyl, or think they're using heroin, but could be either. And morphine, again, has gone down. Polysubstance use is common. The median number of drugs is 3, and 74% of those who use opioids actually use methamphetamine as well. And the survey has been an incredible source of rich information for us. And these are since our 2018 time and 2019. So we now know that people are well aware they're using fentanyl in BC because it's so prevalent. We looked at who owned their naloxone kits, and it's about 70% own a naloxone kit, but it's lower if they smoke drugs, which was a concern, or if they use stimulants. And as everybody knows, you can't use the kit on yourself, you use it on probably somebody else, in which case it's probably a good idea to have one because your friends may be using opioids, even if you're not, or not intentionally doing so. We asked about acceptance of technological solutions and discovered that only 50% of people have a cell phone, and many people will have a cell phone part of the month and then sell it later on. We asked people, we've been concerned about using alone, and we asked people why. And then we also have got investigating concurrent use of methamphetamine with other substances and mode of consumption. This is showing how many people experienced and witnessed an overdose. We were quite surprised. We thought the experience was quite low. And then in this last iteration, we actually asked how many times people had overdosed. So we hear a lot about overdoses, but sometimes it may be the same person. And we found that 25% of those that reported having had an overdose had overdosed 4 or more times. Using alone, this was one we often hear about. People are using alone because of stigma. And what we found was the majority of people who were using alone, it was more convenient and comfortable. They could lay on their bed, they could play their music, they could not have to fight with others to use in a, line up at an overdose prevention site. They didn't have to share with somebody else, because often if you were using with somebody, it was expected to share. But comfort and convenience was the main reason. Not wanting others to know was a much lower percentage. But we have to remember, this is a survey that is done at our harm reduction distribution sites where people are going to pick up supplies. So again, these are people who are using services, so doesn't necessarily pan out to those that maybe have more hidden use, for sure. And 76% of people reported using alone in the past 7 days, some or most of the time. So it's huge. And when as I showed you earlier, that 82% of deaths occur in residences, of which, some of those 60% of the deaths are in people who used alone. So that is a quite concern too. This was something that we found in the last survey, which I kind of hadn't tweaked quite so much in the previous one, was looking at the number of people that inhaled opioids as opposed to injecting. And in 2018, it wasn't quite as high, but you can see in 2019, of these folks who said that they used heroin, 73% said they smoked. And for of those that used fentanyl, 67% said they smoked. So we took this to the coroner and said, can you tell us how many people are dying from your information when you actually determine what the route of mode of consumption was? And we found that over the highest rate, over 40%, was in people that were smoking, that had overtaken injecting, and that had happened in 2017. So that really, helped us to push for some more inhalation supports as well. Peer workers, I cannot say too much about the incredible work that people with lived experience do, that they are just so committed. And we all know that it's best practice in harm reduction, their programs and research to include peers who are the experts in their own experiences. And they can help create safe spaces for people who use drugs and build connections and trust. And they also help to prioritize the issues and help us identify nimble responses and solutions. So they can think out of the box. I think many of us that are in more academic practice perhaps are constrained by the methodology that we use, but peers are just fabulous. We did the peer engagement and evaluation project, and this was a 3-year project which really helped to develop some of our principles and practices. So around paying peers, about engaging peers, and around language that should be used. And then using that as the sort of the basis, we've gone on to do other projects. And this is one that is actually happening at the moment, and it's called Peer-to-Peer, and it's mixed methods, multi-phase, participatory community action research design. And we did focus groups, which were really like a needs assessment to work out what it is that people who were working in overdose response environments needed. And we developed, there were 3 major themes that came out. They wanted recognition, organizational support, and skill development. And they wanted it for everyone. I won't go into this, but I think everybody knows that the working conditions of peer responders they're stigmatized by their colleagues and other professionals. They're not often given the skills or the ability to refer people, and it's emotionally taxing. Their everyday lives are really stressful as well, and they're always on call. So not only do they respond, and that's their employment, but when they go home, they also care for members in their community. So not like myself, who can come home and relax and switch off, they're always on call. and trauma and grief, and the coping mechanisms and supports they need. We heard was they wanted supports from other people with lived experience. They didn't want a professional coming in telling them what they should do. And we often talk about resilience, and one of my colleagues always tell me that people who use substances are some of the most, they're not vulnerable, they're some of the most creative, resilient folks you can imagine from what they've lived through. And we often use the term burnout, and to me, burnout is trying to blame the individual when really it's a systemic or an organizational lack of supports that's there. So we've got some various things, and I'm happy to share my presentation, and this is just describing the various items that we identified. And we're very lucky to have a very creative research assistant who is not a peer, but is very artistic and does lots of drawings and things for us. So this is what we found. So the recognition, we developed a video about the day in the life, and we developed business cards and photo ID, which professionalized the role. And the next step was to do some meet and greet with other professionals using that video as a, and we've also done some modules with stigma reducing modules, but as yet we haven't connected because we've had problems with COVID, obviously. Job descriptions, guidelines, orientation, debriefings, team building days were put on hold as well. And then skill development, sort of first aid, CPR and other things. So those are the pieces that have come out. And then as we've been seeing, and I mentioned, we know that there's been an increase of benzodiazepines and their analogues in the opioids. And, you know, it was hard to respond to an overdose, that you would give somebody naloxone, they would start breathing, but they remained unrousable. So we decided that we would do a project and offer oximeters to our responders and see how that was. And what we found was it was very positively received, that there are obviously drawbacks, and sometimes you pick one up and it didn't have a battery, the battery was needed new batteries, and occasionally it wasn't working properly, but generally speaking, the responders really found it was helpful and professionalized their role. So this is the video, and there's various versions which you can try, and this is some of the modules. So what have we done with opportunities with COVID? Some of the things, we've had increased money and benefits for people who use substances, which has been fabulous. We have Health Canada have said temporarily that supervised consumption sites, the decision if you're making changes can go to the provinces, and there's an intent to review the decisions certainly that are happening there, and trying to work out what we can do better. What we do know is that we've increased support for peer-led initiatives, that peers have come to the fore, and overdose responses for people with lived experience. And this again, you can see the everyday superhero carrying naloxone. The other thing that's happened is that people who are living in encampments, they have found accommodation, hotels, temporary housing, and also for those in isolation. And I'll talk a little bit about the other items there. So a lot of the information is not accessible to people who use substances. So we created our own, working with the peers, with our artistic research assistant. We have risk mitigation guidance, interim guidance, which allows and encourages physicians to prescribe Cadian, hydromorphone, Meslon for people. It's really to reduce the withdrawal. It's not safe supply, which is what a lot of people call it, but it's so that people perhaps can stay in their own home and not have to go and buy drugs on the street, and also because the street drugs are so toxic. The Lifeguard app is a phone app. As I mentioned, 50% of people didn't have a cell phone, so we've also identified ways of getting people phones. And this is really what it is. It's one of these alarms. You press the button when you're about to use, and the alarm will go off at a minute, and then it starts vibrating, flashing, getting louder. And if you don't cancel it, emergency health services will be sent. The information that you put in where you are, you register in advance, but if you're somewhere else or you want to put in where you are, that information isn't shared with anybody unless they have to send paramedics out to you. We've been lucky that our ministry has committed to more supervised consumption sites, including inhalation sites and including a wider array of inhalation supplies, including pipes, and also have committed to doubling addiction beds over the next 3 years and having nurses who will be able to prescribe opioid agonist therapy. This is just a graph, I'm just coming to the end now, which really shows, and part of the reason why I think many of our folks who use substances feel neglected, that so much time and energy has been placed on COVID. Obviously, we're seeing a lot more cases now, and it's, you know, it is really important to work with COVID, as you all know, having hopefully be coming out of your lockdown. But if we look at the number of deaths, there's a definite differentiation in the number of deaths that has happened. So what I've talked to you about is applied public health, collaborating, data sharing, working with people with lived experience, having an ongoing survey that we can use to add questions, to evaluate things, and making sure that we do knowledge translation. Thank you.
Thank you very much, Jane. That was fantastic. Clearly, the breadth and depth of the data and also the response is quite amazing. So at this point, I'd like to bring in Dr. Nico Clark to the discussion. And so we'll have a bit of a panel discussion here, Jane. And then also just a reminder after that, please send through your questions using the Q&A function, and we'll get into and answer some of those questions at the end of this discussion. So please use the Q&A function for those attendees. Jane, obviously there's 5 health authorities, as you put up in one of the slides in BC. I was really curious, have you had any challenges to the implementation of these harm reduction strategies presented by the 5 health authorities? I know in Victoria there's some models that are similar to that, and a lot of subcontracting goes on. I just wonder if that kind of has presented any barriers.
Well, I can certainly give you one example. I've mentioned the risk mitigation guidance, which is being able to prescribe during the pandemic. We have one health authority that has not prescribed at all. That the physicians there in their group decided that that wasn't for them. So there is, and also if we look at the overdose prevention services, that same health authority is one where the numbers are very, very low. It's also one where we have that mobile unit that you saw that was in 2 different sites. So there are most definitely differences within the health authorities. It's also, you know, Vancouver is very different, and we have a lot more resources there, but they are planning on opening an overdose prevention site in Yale Town, which is just slightly east of the downtown east side. And there's been a lot of people who are against that. And it's really hard. I mean, when we started with the overdose prevention site, the first one, thankfully Vancouver police were well on board, but we also come across other police that are not so supportive, municipalities that the mayors do not want it and it's not in my backyard. So I think we see that frequently, but over time, and the sad thing is because we've seen so many deaths, we now have very vocal parents. We have so many more people who know somebody who has overdosed, who has died, that the message slowly gets through, but we still have the not in my backyard and go somewhere else, please.
And Nico, is that something that you can potentially expand on and or relate to?
Oh, thanks, Jesse, and first of all, thanks, Jane, for the fantastic overview of the update on what's been happening in Canada and British Columbia in particular, and the dramatic changes, I would say, that have happened in this period since COVID has come about, and the various impressive measures that you've done to monitor that and to influence it in a positive way. Yes, so on the specific point you've raised, yes, certainly there's, remains very controversial here, obviously, as to what is the best way to respond to drug problems in our society, particularly when it comes to issues of sites of supervised drug consumption, and we have a discussion in our society at the moment as to where there might be a location for a second injecting room, which is kind of for which there's considerable debate at the moment. As you know, we just have the one at the moment. So, look, the short answer is yes. There's differences of opinion about that. But I think our experience has been that that there's been certainly a dramatic uptake in the injecting facility that we've opened. I was comparing our numbers to the numbers that you've had in British Columbia of 60,000 a month. So I mean, in 32 centres we have about 10,000 a month pre-COVID, and it's gone down about 16% in the COVID era. And we've kind of started at about 200 overdoses a month, and that's really dropped dramatically now with COVID. There's been major disruptions to the drug market here in Victoria in the COVID era. We don't have such up-to-date information as you do. That's really kind of impressive. You've got such recent overdose and coronial information, but the data that we've had from the injecting room certainly shown that there's been big reductions in availability of both methamphetamine and heroin. I don't know, Jesse, if you wanted me to comment more broadly, or what should we have it?
One of the other things that I was actually really interested in, Jane, is you mentioned that there's been kind of a switch in the mode of administration, or at least an uptake in inhalation and overdoses related to inhalation. And then you mentioned some inhalation specific supports, and also kind of safe consumption site design around inhalation, if I got that correct. I just wondered if you could briefly expand on that. And then Nico, I'd like to get your perspective around inhalation of kind of opioids, et cetera, here in Melbourne, and whether there's the scope for or the need for something similar in Melbourne.
Yeah, thanks. Just sort of going back to a couple of points, I think one of the ways that we managed to actually get OPS sites in certain communities was actually finding a champion. And that champion wasn't a harm reduction advocate, a person, it was somebody in the community who actually championed it, and that was really helpful. And we have found the overdose prevention sites more popular than the supervised consumption site. They're less clinical. They're usually run by people with lived and living experience. So certainly that was the way we went. As far as the overdose prevention sites that have inhalation, we currently have a number which are kind of like outdoor tents, which have kind of flaps down on a number of sides. We're actually piloting a new study that we just got funding for, which is to use oximeters, which are continually monitoring, so that the individual that is observing doesn't have to be exposed to whatever somebody is smoking, that they can be behind a wall, and behind a glass door, and can still see if somebody slumps what's going on. As I said, we really were concerned, and when we found all these pieces, that our ministry has really pushed to help get overdose prevention sites that are inhalation sites. It's not easy, you know, trying to retrofit somewhere and trying to make sure that everybody's safe. And the places that where you've been doing this is like some of the hotels where the encampment folks have gone. But one of our big barriers is coming up on trying to work with WorkSafe BC, so the occupational side of things. So that's really quite a challenge. But generally it's well supported by staff and obviously by the clients. But we still have a few things, we've got a number that are happening, but we still have a few creases to iron out.
So we don't have as much smoking of opioids in particular in Australia, partly because the heroin is not as the same kind as in Europe, which is kind of more which is more readily smoked. So it's partly the way that the heroin market operates here, and partly it's a cultural thing. So there's you know, there's a line of thinking that says let's kind of encourage people to smoke and not inject, so because we may both reduce bloodborne virus spread and reduce overdoses. It's interesting to see that you've got significant overdoses even in those who are smoking. I think maybe that's particularly a fentanyl thing, and I'm not sure whether that's the same for heroin. There's certainly a lower risk of overdosing from heroin in smoking generally than with injecting it. So we don't have a big demand for kind of a opiate inhalation spaces at this point, but that doesn't mean that we shouldn't be encouraging people to kind of inhale rather than inject, and providing the location, the space for them to do that. But there are certainly workplace considerations, as you mentioned, Jane, that make it a little bit logistically complicated.
Yeah, and we're just about to add some questions to find out why people are smoking the opioids. Is it because they think it is safer? And obviously fentanyl works so quickly that, you know, if you're smoking and you're using alone, then it can be, you know, obviously quite dangerous. So I think there's a lot we don't know. So that's our next piece, and also just to see how quickly people's oxygen saturations go down. And that's part of what we'll be doing with the monitoring study that we're about to do, because most studies are done in the anaesthetic room through injecting.
Yeah, just to add that just to confirm, we've had very low rates still of fentanyl in the illicit drug market in Australia. Most of the fentanyl is diverted from the pharmaceutical market. In the injecting room, we test people every 6 months, and we've only identified one couple who've had a confirmed fentanyl in their urine, and they bought it from somebody who bought it from overseas. So there doesn't appear to be kind of any evidence of kind of synthetic fentanyls entering the injecting market in Australia. But it's certainly interesting that what you start talking about, the role of kind of pulse oximetry devices. There's certainly, we've been, we're considering how we might be able to kind of incorporate some of those efforts here, but yet we haven't got to that point.
And I think because we have so many peer responders, that it's from them that we're trying to support, so they actually feel more in control, and that's certainly what we found as well.
And Jane, and this is open to you both, but I was really interested as well in that study, Jane, where you established that convenience and comfort was the major driver of using alone, essentially. And I was just wondering how that influences either Jane or Nico, how that influences your harm reduction thinking and approach in this area. I mean, we've discussed a bit of that, but I wonder if either of you could kind of expand on how that kind of changes or is incorporated into your thinking.
So from my perspective, it really highlights that we need a safer supply, that people know that they're using fentanyl, but they will still use it alone. So because nobody knows what it is they're using or what the potency is, that to actually have that safer supply so people can use alone more safely, I think is important. You know, it's not that somebody is hiding their use. This is somebody who is often has been using for a considerable amount of time, but they still wish to use alone because it's more convenient.
I think we have similar data on the number of overdoses people have experienced, and the number of overdoses people have witnessed. I think there's kind of similar patterns in our population than in the Vancouver population. When we ask people why they're not, for example, injecting in the supervised injecting room, they'll most commonly tell us that it's too far away from where they're living. But you know, that's less of an issue for you. I guess you've got multiple rooms dotted around Vancouver, whereas we really only catering to the Richmond drug market in Melbourne. But you know, there are some people who also indicated that they kind of prefer to inject in their own homes if they have one. And you know, I think the COVID Safe app that you've got, well, not sorry, the Overdose app that you've mentioned is really interesting. I don't know if you've had any success with that. We've had some initial efforts to try and create one, and we found it's difficult to kind of locate people accurately enough with the GPS for it to be a reliable device. I know people have to insert their address, but whether or not you feel that that's going to make play a significant role in overdose prevention.
From my perspective, I think we need a whole array of things, and I think that probably is something that maybe somebody who is unlikely to use an overdose prevention site can use. The concern is in very rural areas that it can take people a long time to get there. So who is it that we're alerting? It doesn't go through our 911 system, it goes through another system, so that there isn't a record of this coming through the 911 call center. There is another, and the reason this one got really sort of pushed forward is because it's supported by the BC Emergency Health Services, and they got some funding from our ministry to kind of move with it. There is another one that we do have, which is more of a at the user level, which is you're connected with somebody, and it goes, when the alarm goes off, it's with somebody who's local, who often is a peer themselves, and can respond as needed and can contact your nearest and dearest or somebody. So, you know, there's lots of different ways of doing it. I think it's people with lived experience have been very wary of using. They're concerned about what data may be collected, because often they're supposed to put in what they're using and how they're using it, and that's a concern as well for people.
Brilliant. We've got some interesting questions coming in on the Q&A, so maybe we'll switch to that. We've got an initial question from Stan Cap, who says, welcome Jane. In Melbourne, we are looking to have a new safe injecting room. There's a lot of public discussion and strong views both ways about the value of supervised injecting room, but the location is under discussion with concerns about resident amenity and access. What advice would you have to assist in finding a suitable location that satisfies access and amenity concerns?
Yeah, it would help if I unmuted myself. Yeah, it's a challenge, and often people are more anxious beforehand than they are when it actually opens, because they do find that there's less needle litter. There isn't, you know, things that the people are concerned are going to happen just don't happen. So sometimes it's been implemented and people have said, okay, this is fine, we're all right. We do have a lot of community consultation, and there's always the not in my backyard, and there's no perfect place, but it has to be used. And for us, I think the more services that we have, the better. One of the things we have introduced is what's called an episodic overdose prevention site, which means that a staff member can assist somebody who wishes to use in any health facility, so in a health unit. And there's recommendations how that happens, that it's the nurse or whoever is happy to supervise, the person can use, and then that works fine. So, you know, it's a way of just trying to make sure that we have as many different options as possible. But you're right, people aren't always going to be happy.
Nico, your thoughts?
Look, I think you have to put where your drug market is. I think there's really good evidence from Vancouver that the biggest impact on overdose rates is within a kilometre of where people are buying their heroin. I think you know, we have you know, our one experience so far in Melbourne is of you know, it's a very large market, the drug market in Richmond. I don't know that, you know, people kind of fully appreciate it's a kind of you know, we have kind of quite a concentrated heroin market in Melbourne, and despite having a very busy injecting room there, you know, the drug market is kind of, if this was in Vancouver, you could have 3 or 4 injecting rooms of the same size, kind of catering to that one market. And so I think if we had that, then you would kind of see probably a bigger impact on the visibility of that market. But you know, certainly we've seen positive impacts in terms of reductions in the overdoses in the kilometre around the centre. I think there is still a large drug market there, and so it becomes difficult for it's not going to vanish from the streets overnight with one injecting room, and so that's led to some concerns from residents who might have expected that to happen. You know, I would say that we need, if we want to see more positive impact from injection sites, we need more to kind of determine the benefit to kind of see the impact that they can potentially have in taking drug injections off the street and into safer environments.
I mean, our challenge is our overdose rate, our death rate is the same throughout the province. It's the same in the Vancouver coastal as it is in all our other health authorities. But of course, the population varies, and having one OPS site in a huge area in our northern region, it's only a few people that can get to it. So it's just not going to be effective. And that's why we hope that we can get more of these episodic overdose prevention services in place so that people can just go to a health unit, and when they pick up their supplies can say, hey, I would like to use here, is that okay? And somebody's there to support them if they need help.
And just expanding on that briefly, Jane, inevitably you have a bit of a interaction in this area between health and law enforcement for what it is. And I'm just wondering how your experiences in BC have been with engagement with law enforcement around the consumption side idea, and if that's evolved over time, or if you could just expand on that. And then maybe Nico, you could chime in on your experience here in Australia.
Well, I've been around for a while, so I was involved when we were actually setting up the supervised consumption site, Insight, way back when I was a field epi. And then the Vancouver police were involved, and they were supportive. We have a mixed sort of police forces here. We have the Royal Canadian, the RCMP, who are federally kind of told what the regulations and what they need to do. And then we have the municipality. So some of the cities have their own police force, and those are often the ones that it's easier to work with. Our Chief of Police Association have come out with a policy document supporting decriminalisation, saying that nobody should be charged for possession of substances. And there was also from the federal side of things, Justice Ministry was saying that, you know, let's not arrest people for substance use. Let's, you know, use our time better. So, you know, we are getting the support from enforcement. It's been slow in coming and it's not widespread, but that certainly has been helpful. And because I lead the Drug Overdose and Alert Partnership, I have police in Abbotsford and Vancouver and Victoria who are very supportive of harm reduction. And, you know, the classic, we're not going to arrest our way out of this, and overdose and substance use is a health issue. So it's changed, certainly changed quite dramatically in the last 10 years. And it's just so tragic we have to see so many people die for the actual attitudes to change. But we need to jump on this and make sure that we move forward.
And Nico, how's your experience been with the engagement with law enforcement around the center that you work in, if you feel comfortable?
Oh, look, yeah, I can say we work very closely with the local law enforcement. We meet regularly with them. But, you know, they've got their instructions, and I would say, generally speaking, that policing is, you know, the kind of approach in Victoria is on a different point on the kind of harm reduction spectrum to that of the Canadian police. There's a, you know, despite kind of in some ways the kind of policy moving towards not in arresting people for possession only, there's still large numbers of people who are arrested for possession charges. And we've, you know, in the last few years, we've seen increasing numbers of people in prison on kind of those charges. Whether or not that's a kind of a deliberate policy or a result of some of the other policies on bail and kind of some of the way the system is operated is less clear. But, you know, certainly, you know, having had a chance to see the way the situation is in Canada, there are some things that would happen in Canada that wouldn't be tolerated here from a policing perspective. The kind of people setting up kind of overdose prevention sites in parks, kind of in a semi or unauthorized way would you know, that wouldn't kind of, I can't see that, I can't imagine that happening here. So I think there are different perspectives on from a whole of government approach on, you know, and I think the government is kind of probably saying, well, you know, let's have kind of harm reduction overdose prevention sites, and let's have a policing approach at the same time rather than having one over the other. But, you know, having said that, we do work closely together. There's kind of things that are in the pipeline to look at diverting people away from the criminal justice system towards therapeutic options whenever possible. I think there's certainly an awareness that kind of everybody's better off in that, if that happens, for those people who are kind of suitable for that and interested in that. But it's still, you know, within systems, it's kind of, you know, a little bit difficult to set those up in a streamlined way still.
Thanks for that, Nico. I'm going to move to another question here. This one comes in from Tom Lyons. He writes, hi, Jane, Tom Lyons from Victorian Health Department, Alcohol and Drug Policy. Can you comment on the contribution of the novel benzodiazepines to acute harm, especially relative to the potential synthetic opioids? In Australia, we have seen some of these novel benzos, but not really the fentanyls at all.
Yeah, I mean, I think we were surprised to see so much, and atizolam, you know, we were seeing alprazolam, but atizolam is the one that's taken over. And that's not prescribable in Canada. It's obviously obtained from the producers and then it's added. And we've been hearing different reasons that it may be added, maybe due to the lack of fentanyl, maybe, you know, people wanting to have that longer feeling of well-being, maybe because people perhaps won't notice that there isn't so much of the active ingredient. It's hard to know why it's added. It's a huge issue in the UK as well. I mean, that's one of their major issues around the atizolam. Our concern really is that combination. I mean, obviously fentanyl is can be deadly, And then if you're mixing that and adding another suppressant on top of it, like a benzodiazepine, then that can just be enough to make people, go into respiratory arrest as well. And it's not obviously reversed by naloxone.
And Nico, have you seen anything similar in terms of kind of, for lack of a better word, an adulterant kind of benzo intermixed into the kind of heroin or opioid supply in Melbourne?
Look, there's some evidence that it's there, but it's not on the same scale again as the Canadian experience. If you look at the recent coroner's data, I think about 3% of overdose deaths had some atizolam in them, compared to 3% of benzo deaths were atizolam, compared to much higher rates for other benzodiazepines. So, many of the overdose deaths are kind of mixture of, including benzos, but the role of atizolam in that at this stage is minimal. We're certainly kind of seeing, people, we see waves of kind of people reporting that there's a kind of an illicit benzo on the street. In the past, it was alprazolam, and now, again, atizolam's unprescribable in Australia. But it's not on the same scale as it is in Canada.
And here's another question from, this comes in from David de Cologon. Is naloxone nasal spray used in the THN, the take-home naloxone kits in BC, Jane?
No, our kits are injectable, and we have 3 ampules. We started with 2, and as fentanyl came in, we realized we needed more. We do use the intranasal in situations like the police carry intranasal. It's available for our Indigenous communities, so First Nations folks, they can get it through their alternate benefits. We have a challenge around the costing, and at the moment there is only one company that provides and is licensed to provide in Canada. And as I mentioned, we had 29,000 kits go out in 1 month. If we were paying $100 per kit, it would not be sustainable. And obviously the injectable is much less. But also the majority of people who are using our kits are people with experience of substance use and are comfortable and quite able to administer the injectable. And we know that it's the actual response is fairly standardized, whereas there are, potentially with the intranasal. But, it would be great to have that as an alternative, but we can't at the moment, but it is available. People can buy it. The police, corrections, First Nations have it. Many places where people are not, certainly, in shopping malls and other places, sports centres where there's AEDs. We're looking and have started working with St John's Ambulance to have intranasal naloxone available, because we know people won't be trained in how to inject. So, we're expanding the intranasal, but our kits themselves have the injectable. A long-winded answer, sorry.
No worries. Just another, more of a statement, but something that we could possibly expand on, comes in from Nicole Hallahan. Great to see peer workers held in such huge regard and recognized for the expertise and abilities to build relationships with people who use or who inject drugs. We need peers, given this recognition in Australia and Victoria. Peers have only really come into their roles with the take-home naloxone programs in Victoria. We can learn a lot from the British Columbia model. Jane or Nico, do you want to expand on that? From my perspective, I think it's fantastic. I've done a bit of work with peers in the incarceration space, so around kind of navigating after the health system after release from prison, and obviously there's a fair amount of face validity and trust that's established. But I really enjoyed what you said, Jane, around the need to support those peers, because it does put them at a nexus of a very challenging environment on top of the challenges they already experience. So be good to expand on that.
Yeah, and I think, you know, if you're somebody who's on a salary and working at an overdose prevention site or a supervised consumption site, you know, you get sick pay, you get holiday pay. Peers get none of that. They're working flat out because they believe they need to help people. They get, you know, really challenged, and obviously their personal experience and reliving overdose and things like that can be really challenging. And I think we just do not show our appreciation in the way that we should. And I learned far more from people with lived experience than they ever learned from me.
And Nico, have you had any involvement with peer work in Victoria that you could expand on?
We at North Richmond has had some that, look, I would certainly echo what Jane was saying. I think the work in Canada with peers is fantastic, and I think we could learn a lot from the role that peers have in Canada, have a kind of much larger role than we have here. I think there's wide recognition of the value of peers, but sometimes I think we struggle to know how to involve people. I think there's a sense that if we shouldn't kind of people shouldn't work for less pay than there's kind of challenges. Are they employed or not employed? And if they're employed, then they should be a real employment and not a kind of low value employment. But I think we could do a lot to learn from the role of peers in Canada.
And to try not to be tokenistic, I mean, I've seen examples where, you know, peers have been consulted, but it's usually too late and decisions have been made, or, you know, anybody that's involved is expected to be in recovery and is not allowed to be actively using. So I think that there's lots of examples where perhaps our own biases come in, and it's difficult for people to accept sometimes, depending who they are, that people with lived experience and people who are using substances have so much to offer.
Great, and I think we've got time for just one more quick one, and this is a follow-up from Stan Kapp, who was talking about the safe injecting rooms or safe consumption sites. He says, thanks, can we use hospital sites, or mobile units? And I'd imagine that's for the Victorian context, and maybe I'll pass that to you, Nico.
Well, I think we can ask Jane. I think Vancouver has a hospital site of injecting room and mobile sites. So it's probably, maybe Jane, it's more relevant for you to comment on that, I think.
Yeah, I mean, at St Paul's Hospital there is an overdose prevention site, and that was purposefully, that's the hospital that a lot of people from the downtown east side will get taken to. So rather than somebody having to leave against medical advice and not be allowed back in and stop receiving their antibiotics, or whatever reason they may be in hospital, they can actually use the overdose prevention site on site. And certainly mobile sites work well. But again, the episodic opioid overdose prevention sites is what we're really trying to socialize, and that's allowing people when they're in hospital to be able to use as well.
And one last question, just quickly, from Malcolm Dobbin. What is the contribution of pharmaceutical opioids to opioid overdose deaths? We've got 60 seconds.
Not a lot. Zilch. Yeah, it's not a problem in BC for sure. It's more out east, and yes, the contribution may be there from introducing the addiction piece, but as far as the deaths are concerned, it's not prescribed opioids that are causing the deaths.
Brilliant. Well, thank you so much, Jane, and thank you, Nico, for your time today. Really appreciate it, Jane. Wonderful presentation, and thanks, Nico, for your insights from a Victorian context. We'll let you two both go now, and we'll move on to the second part of our early morning here. Thanks again to Jane and Nico for their wonderful presentation and insights. And now I'd like to just introduce our next session and briefly introduce Professor Dan Lubman and Steve Michelson. And they're here to talk about the exciting new 4-part series on SBS titled Addicted Australia. And this is part of Turning Point's Rethinking Addiction campaign. The link to that particular campaign is https rethinkaddiction.org.au. And so welcome, Dan. Professor Dan Lubman is the director of Turning Point and professor of addiction studies and services at Monash University. His research is wide-ranging, and he has published over 380 peer-reviewed scientific papers, book chapters, and major reports. He was chair of the Royal Australian and New Zealand College of Psychiatrists Faculty of Addiction Psychiatry for over a decade. He is regularly contacted for policy advice and community comment, and sits on numerous state and Commonwealth expert reference committees, including Victoria's ICE Action Task Force, as well as its Mental Health Expert Task Force. Welcome, Dan. And I'd also like to introduce Steve Michelson. Steve Michelson is the founder and managing director of Michelson Alexander, a strategic communications firm that focuses on positive social impact. Steve and his team are highly respected advisors and campaign strategists. Michelson and Alexander has experience working with a diverse range of corporate, government, and not-for-profit sector stakeholders. Steve, Dan, over to you.
Thanks very much, Jesse, and thanks for everyone for allowing us to be on this program this morning. Some fantastic talks this morning, and really thankful for the opportunity to talk about the Addicted Australia documentary and the campaign to rethink addiction. So just to give a bit of background, we were approached around, it must have been about 80 months, 2 years ago, by Blackfellow Films. And Blackfellow Films are an award-winning film company who do a lot of work, particularly for SBS, around social justice issues. So they've done work in the Indigenous space, they've done work in the space around homelessness, mental health, domestic violence. So really look at these sort of areas of social justice and really look to inform broader audience around some of the key myths and misconceptions around that area and what needs to happen. And so we were approached, Jacob Hickey's the producer, came and talked to me about some of the things they were doing. They wanted to think about doing in the addiction space. And the original idea that they came up with was thinking about, doing an episode or a documentary around essentially a rehab over sort of a couple of weeks. And I think one of the things that we talked about was the sort of multiple misconceptions in the community around what addiction is, who it affects, and sort of what is available in sort of treatment. And one of the things that we talked about quite strongly was around the issue that most people don't realize how prevalent addiction is. They don't realize how many individuals it affects, both across different age groups and different backgrounds. The community view is treatment doesn't work, and if you do need treatment, the only option is to go to rehab. And so the importance of portraying a model that is much more outpatient-based model. And the final thing was really just around really telling the story that addiction is like any other health disorder and should be treated as such. And Jacob went away, talked to SBS, and they came back and they asked us, would we consider putting together a bespoke treatment program, a 6-month program, and they would advertise and see if they could find individuals, everyday Australians who were struggling with addiction, who would be, and this is incredibly brave, would be willing to share their lives over 6 months and to follow their journey, and to follow their journey not just in treatment, but in their everyday lives. And 10 really brave Victorians put their hand up and agreed to be part of that. And what we've essentially put together for the treatment program is anything sort of special in some ways. We were very clear that what we wanted to present is what you would expect to get if you were treated for any other health disorder. So essentially something that'll be very familiar for everyone here, although unfortunately, we don't often get the opportunity to do it in a wraparound fashion and in a way that's fully integrated, but essentially a multidisciplinary team of doctors, nurses, psychologists, social workers, counsellors, really coupled with peer support, so a weekly peer support group, opportunities for outreach, and linked to a strong family support group. So that whole wraparound package, and offering that for 6 months, so guaranteeing that this is a 6 months program that people could choose from whatever element they wanted, and they knew they were going to be supported. Plus, we were offering through our telephone helplines sort of after-hour support for people who were really struggling. And I suppose going into the whole documentary, it was a huge risk for all of us, I think, on so many fronts. Risk around whether people will put their hand up to be involved. A risk around would people stay the course, and would this sort of what we were trying to demonstrate, how would it look? And a risk with Blackfellow Films that would they be able to show the human story of addiction in a really sort of compassionate way that really addresses so many different myths and misconceptions in the community. And I think what happened overall is that it's been a really fantastic experience. It's been obviously a lot of hard work and challenge, but we've had these 10 brave individuals who basically come from a whole range of different backgrounds. They essentially have issues with alcohol, with methamphetamine, with heroin, gambling, so things that we see every day. So most of the people in the documentary have issues with alcohol, but different genders, male, female, different age groups, from young to old. And I think what's really powerful about the documentary is that most of the people that you will see in the documentary look like ordinary Australians. Their families look like ordinary Australians. And I think it really, in some ways, really addresses that sort of misconception in the general population around that what the stereotype of addiction really looks like and who they are. And this really just sort of in some ways blows that up in a number of different ways. The people who took part are incredibly generous in terms of letting the camera in, and really unprecedented access. So although we're involved in the documentary in terms of the treatment program, it's really about following the lives of these 10 individuals. And it's really, while treatment has a component of that, it's really about following them, in their everyday lives and with their families. And so it gives this context of this really human story. And as you can see on the slide, there's a whole series of sort of issues and subject matter that will come up, which is, I think, is really important when we talk about sort of potential sort of media and media attention that's going to come up around the documentary. But it talks about the different types of addiction that we obviously saw in the documentary. We talked about the different types of treatment that came up. We talked about the common issues that sort of come up a lot in terms of other mental health and wellbeing issues, other physical health issues, and social cultural issues. So a whole range of different topics are covered. So the show is 4 one-hour episodes, going to be streaming on SBS on Tuesday the 10th of November at 8:30, 4 one-hour episodes. And the whole exercise for us obviously is thousands of hours of footage, enormous amount of work from everyone here at Turning Point, but also working very closely with Shark. So the family support group was provided by the Family Drug Help and supports at Shark, and really sort of thank Heather and everyone there for their support. So a real team effort, lots and lots of filming. And I think what happens in this whole process is that at the beginning, we had to get staff from Turning Point who were willing to be on camera themselves and be filmed, providing counselling sessions, providing medical assessments, providing sort of treatment in detox, and be willing to have that shown on camera. So obviously lots of anxiety at the beginning, but I think when you're been involved in this for 6 months, I think by the end, everyone gets very familiar with it. And also, unfortunately what happens is, despite thousands and thousands of hours of filming, they've got to try and condense that into 4 hours of essential filmmaking. So there's a lot of information that it isn't there, but I think the information that it is, it provides, it's the most real thing that I've seen on addiction and what it is, and how it affects everyday people. So incredibly powerful in that way, incredibly powerful in terms of the struggles and challenges people have in their journeys. So it's incredibly emotional. And I think the thing that Backfire Films have done incredibly well, and obviously they've worked with us very closely on this, is to really nail some of the key messages that, we think are really important and address a lot of the misconceptions that are out there in the public. So I would say the 4 key messages that come out of the documentary are that addiction is much more than just using drinking or gambling. It's so much more than that. It's about underlying trauma, it's about underlying mental health, it's around isolation, it's around connection, it's around social circumstances and socioeconomic issues. The second key point is around that stigma is disabling, and that comes up very strongly in all the participant stories, that stigma is so disabling in terms of seeking help, getting support, and being able to reach out and get the support that they need. The third thing is around change is possible, and we do see some really good news stories in the documentary, and that really sort of, I think, helps challenge some of those myths out there in the community about the fact that, I think one of the prevailing, stories is that, nobody gets better, it's a bad news story, treatment doesn't work. That's a prevailing community myth that I think the documentary really, full on challenges. And the final key point, I think, is with this, the ability to provide that sort of multidisciplinary team and to link it with other health issues, is that, addiction is like any other health disorder, and it should be treated as such. We should be resourced as such. We should have the same level of support and integration and resourcing as we would expect for the treatment of any other health disorder. So I think the key thing here, just to reiterate again, is the program that we put together, is, I think, what all of us would like to offer, but because of the way the system is resourced and funding, it's often very difficult to bring those elements all together in a seamless sort of model of care, and that's what we try to do. And the key message, I think, throughout all of this, for us, is that services, we have amazing clinicians and services working in the sector, but often the system is fragmented and doesn't help people to navigate the system in a way that works for them. And there's so much more we can do if we could have some of this joined up care. So that's essentially an overview of the documentary. We've been fortunate enough to see the rough cuts of the documentary, as has Heather and some of her team at Shark, and I think we've all been blown away by how, what a fantastic piece of filmmaking it is, how powerful and emotive it is, how it really nails the key issues that we really want to address. And I think it will create an enormous conversation and address a whole range of issues around stereotypes and stigma. I mean, one of the things that we know from other areas of health, particularly in the area of, for example, HIV, is that once you can convince the population that something is treatable, that really changes people's attitudes and levels of stigma. And I think one of the things this does, by having this opportunity to have a 4-hour documentary on addiction, which is really about these incredibly brave Australians telling their story and their journey and the issues that they have to face, and seeing that treatment not only is available and it's not some sort of crazy stuff, it's just what you would expect for any other health disorder, and it actually works. I think that will go a long way in terms of really challenging some of those underlying prevailing misconceptions and stigma right there in the community. And I think it will create a whole conversation. So just to briefly just let people know, because I know obviously people will be very concerned, but around this participants' welfare. So just to be clear that we're incredibly supportive and continue to be incredibly supportive of these individuals. So we're regularly checking in with them prior to the documentary and during the documentary, making sure they've got that right level of support around them, and making sure that they keep off social media and that they're supported as much as possible. So we're really putting those supports in the background to make sure that they are supported as much as possible. But I think one of the things for those individuals who've been involved, not only is this whole documentary has not been just about them and their treatment, but part of the reason they've come into this is because they want to make sure that if other people are in a similar position to them as they were, that they wouldn't know, what was available, and the fact that addiction is treatable and there are so many opportunities available. So they're really passionate about making sure other people know that this is something we need to talk about and something that everyone should expect to receive the best possible care. So that's in a nutshell the documentary, how we've been involved and what it's about. Telling these stories of these 10 individuals and their families, really powerful storytelling. But one of the things that we wanted to do is, you don't get many opportunities in this space to have 4 hours of prime time TV, talking about an issue that we're all here incredibly passionate about and wanting a platform to talk about it. So because of that, we've also set up this campaign and brought on board Michelson Alexander to help us develop a campaign that's going to sort of in some ways piggyback off the documentary. So encouraging as many Australians to watch the documentary as possible, because essentially it's a public health message around what addiction is. So it's there to challenge as many people as possible about what addiction is and what the treatment is. Secondly, it's about creating that enormous conversation. And we know part of creating that conversation is bringing out this issue, which we talk about as this, really silent, something that's so silent that nobody can talk about, as we all know. So trying to share those stories. So we've got these 10 brave Australians telling their stories. And so we want to encourage as many people to share their stories as well, to show that it shouldn't be this, this hidden secret, that it should be something that we should be able to talk about. We should be able to have a national conversation about. So part of the campaign is around getting people to share their stories. And we know stories are so powerful in terms of helping people to connect to the issue. And the third thing is around advocating for the addiction to be a national priority and for, for a greater, roadmap around what addiction treatment should be. So what it actually looks like, having a national summit around that and making sort of, really getting the community support around, getting greater investment in the treatment of addiction. So that's sort of the rationale for that. I might just show the video. I don't know if people have had a chance to watch it. This is the current trailer that's out now.
I'm not sure if we've got sound, Dan.
No, it doesn't sound like it's really running. So maybe we leave that. People can have lots of opportunities to, it's out online now. You go on SBS, the trailer's out there. So maybe we'll leave that for now. And maybe what I'll do is I'll just hand over to Steve to talk a bit about the campaign and what we're hoping to do and what it is and how people can get involved.
Hold on, I might be able to get it to work now. Just.
There we go.
Possibility of recovery for every patient.
I just want to be free of the chain to the drug.
Emergency service. Is your daughter responding?
I see something to change. I see something to shift.
Stopped drinking for 9 weeks. Swapped it for this dose.
We're going to win it. We're going to win it together.
Thanks. So I'll just hand over to Steve. if people want to go and have a look at certainly all the materials on the SPS website.
Thanks very much, Dan. And lovely to meet you all virtually. Caitlin, yeah, thanks, that's great. So Steve Michelson's my name, from Michelson Alexander. As Dan mentioned, we're a strategic communications firm with a social impact that's been brought on to help build this campaign. We've got quite a lot of experience working in the areas of alcohol and drug harm minimisation, but also in the areas of addiction. So we've done work with North Richmond Community Health around the MSIR, Co-Health around the site of the second safe injecting service, and now with Turning Point and Eastern Health, which is a real privilege. On the Rethink Addiction campaign, so as Dan said, really this incredible documentary is an amazing opportunity for us to really try and have a national conversation about issues surrounding addiction, and in doing so, to really try and change the story of addiction, the way in which decision makers approach the issue of addiction, and through all of that, hopefully to help reduce stigma in our society. We also know that while addiction is incredibly crippling for those who are touched by it, there are still 58% of people, of Australians, who eventually recover with support. So we'd really like to be, making this a positive campaign, one of hope and one of recovery. And again, through that to be reducing stigma. The centrepiece of the campaign it's essentially online. I should also say this was developed through the thick of COVID-19. So hopefully one day we can build to have some in-person events and activities. But for now, it's very much an online focused campaign. And I think it's been in the chat a couple of times, but the website is rethinkaddiction.org.au. And I might just run through that very briefly just to give people a flavour of it. But firstly, the website, details what this is all about and what addiction is and what this campaign seeks to achieve. It also sets out a number of the supporters who have come on board. And I think it's really important to note that this is an incredibly inclusive and collaborative process. So we welcome everybody on this call to get on board the campaign. I'll come back to ways that you can do that shortly. The website also, though, provides an opportunity for people to post their stories. And it really seeks to emphasise the point that Dan made, which is that we know that almost every Australian has been touched by addiction somehow. So whether it's an individual who's been touched by an addiction, a family member who's supporting that person, a friend, a community member, a neighbour, someone from a sporting club, we're really wanting to use the website as a platform for people to submit their real stories. And if you jump online, you can see there's already a few that have been posted to give you a bit of an idea and some guidance notes. And, through the posting of real stories, we hope to generate that national conversation around addiction and to really emphasise the point that ordinary Australians are touched by addiction in so many different ways. At a very practical level, people can post their stories by uploading a photo or a video. Importantly, we make sure that those materials are curated and edited before they go live. That's not about censoring people. It's just making sure that we follow relevant guidelines and get the tone of those stories right. And of course, we want to make sure that people who post stories who are in need of support get that support. On the website, we're also encouraging people to sign up to the campaign. We're planning on building out quite a successful EDM or electronic distributed mail series so that people are kept informed about the campaign, have different opportunities to get involved. And of course, there are also the social media channels being Facebook, Twitter and Instagram, where people can get involved in the campaign as well. We are acutely mindful that this is a very sensitive topic for many people. And so the website also has a support page where people can seek, telephone, online support and other supports as well. So as you can see on the slide in front of you, we've already got a fantastic list of partners. from across the sector who are coming on board with this campaign. And we'd absolutely love you to do the same thing. And, you know, what's incredibly important, I think, is that we build a coalition of support from within the AOD sector, and not just, you know, here in Victoria where Dan and I are based, but also nationally. You know, the SBS documentary series is screening nationally. So there's an incredible opportunity to build a truly national conversation. And the best way for us to do that is to build that coalition of support, you know, from within the AOD sector, and for us all to see that common interest, you know, in building that national conversation about the issue of addiction. And then over time, what we'd also like to do is to build out the level, the number on and type of partners in the campaign across civil society. And importantly, this is not about, you know, being liberal, Labor, progressive, conservative. It's not about coming from the business community or the union community. It's about coming from across Australian society and coming together to say that by working together, we can have that national conversation about addiction. And as Dan said, there's a couple of specific calls that we're making from the campaign. The first is obviously for the issue of addiction to be that national priority. We're also calling for there to be a national summit on addiction, where we would see, you know, experts in the field, decision makers, stakeholders alike come together to then also, 3, create a roadmap on addiction, a national roadmap on how we can better tackle addiction and addiction related issues. And finally, we're also calling for a dedicated research fund on addiction to be established. So Caitlin, I might just get you to bump to the next slide. Sorry, just move. Yeah, that's it. Thank you. Just in the couple of minutes left, just very quickly about how you can get involved. Please consider becoming a Rethink Addiction partner for change. So that would entail, you know, having your organisation's logo posted on our website. And also, you know, we would then call on you to help spread the word about the campaign across social media channels and other communications platforms that your organisations may have access to. And then finally, you know, it'd be fantastic to work with you all on sourcing and creating content that helps to destigmatise addiction, but also to help build that national conversation. It's also just worth noting that behind all of this sits some engagement with news media, whereby, you know, off the back of a lot of the media that's coming out of the SBS documentary series, we're also hoping to shine a bit of a light on, you know, this campaign and the fact that we are having such a coalition of partners come together from across the AOD sector. But also we're encouraging people to talk to decision makers to get this on people's radar. And so throughout the course of the campaign, we'll also be planning on launching a petition that would obviously very much, you know, pull together in collaboration with this group. And just finally, there's one more slide. You can see here the suite of platforms that we've developed for the campaign. So the website I've mentioned, please log on, have a look. We'd love your feedback, your input, and of course to have you on board as a partner. Facebook and Twitter is there, as well as Instagram. And we're really encouraging people to use the hashtags, particularly Rethink Addiction, during the screening of the SBS series from the 10th of November, as Dan mentioned earlier. My contact details are there, as are the contact details of Andrew Stewart in my team. And we'd absolutely love to hear from you. So please feel free to get in touch by email or by telephone, and very happy to answer any questions there may be in the couple of minutes remaining.
Thank you, Steve. And thank you, Dan. Those wonderful presentations, and really such an important social movement to, you know, help rethink addiction. So congratulations on launching that, and I really look forward to not only viewing the SBS series, but getting involved myself. Do we have any time for, it looks like we're just about at time here. So maybe I think what I'll do is, if anybody does have any further questions for Dan or Steve, please send them through to vada@vada.org.au, and we'll endeavor to get any answers or communication from Dan and Steve regarding the Rethink Addiction platform, and also the SBS series to be aired soon. I'd just like to thank again Jane, Nico, Dan, and Steve for a wonderful webinar. And I just would take this time to introduce webinar 3 of the VADA Service Providers Conference. So this will be on COVID-19 and the AOD consumer. It will be held on Thursday, November 12th at 10:30 a.m. So the same start time as today. This 2-part webinar will investigate how COVID-19 has impacted AOD consumers. Part 1 will feature a presentation and cross-panel discussion hosted by the Association of Participating Service Users, the APSU, discussing their observations and findings regarding AOD consumers and COVID-19 and the associated restrictions. Part 2 will feature a cross-panel discussion regarding the quarantine lockdown of the public housing towers in Flemington, Kensington, and North Melbourne. This discussion will feature contributions from Flat Out, Harm Reduction Victoria, Victoria Police, and the Department of Health and Human Services. For more information or to register, please visit, I believe Julia or Caitlin will be posting a link in the chat here at the end. It's an Eventbrite link, so please click the link, and there it is in the chat. Brilliant, so please click that link and register. Again, thanks to Dan, Steve, Jane, and Nico for the contributions. And please get involved in Rethink Addiction, and please do watch the SBS series.